Hi, this is Giulia and welcome to the Superior Vena Cava Syndrome lecture. Let's get started. What is the Superior Vena Cava Syndrome? It's a constellation of signs and symptoms that is caused by a partial or complete obstruction of blood flow through the superior vena cava. What can be obstructing the superior vena cava? So the obstruction can be due to external compression, internal obstruction, or neoplastic invasion of the vessel wall. So let's have a look at the superior vena cava. Here it is. It's a very thin-walled, low-pressure vein that provides the route for most of the blood that comes from the head and from the neck, from the upper extremities, and in part from the mediastinum. It can be easily compressed by many structures because we have the trachea here, a lot of lymph nodes, then we have the aorta, and of course we have the lungs. So there are many structures that can actually compress the vena cava. What is the emergency? Even if it rarely can do that, sometimes when it's severe, patient can die from respiratory failure or brainstem herniation. So this is why it's included in the oncological emergencies. What are the causes of SVC syndrome? So malignancy is actually the most frequent cause with 65% of the cases. A tumor can obstruct the SVC in different ways. So if this is the superior vena cava, we can have an external obstruction. So if the tumor is growing externally, it can kind of compress from the outside. Or if the tumor is actually on the right side of the body, it can grow inside the wall, and in the end, it can partially or completely obstruct the SVC. The most frequent malignancy that causes SVC syndrome is lung cancer. Both non-small cell and small cell lung cancer can cause SVC syndrome, and when the growth is on the apex of the cancer, then we call it Panco's tumor. Other frequent causes of malignant SVC syndrome are lymphoma or also metastasis. Less frequent tumors might be germ cell cancer or thymoma and so on. Let's discuss about the benign causes of SVC syndrome. Actually, 50 years ago, we used to have a lot of infectious causes like syphilitic aortic aneurysm and tuberculosis, but now they are very rare. The most frequent benign cause is thrombosis in patients that have intravascular devices. Less frequent, as we said, are syphilis, tuberculosis, fibrosing mediastinitis, or hypertrophy of the thyroid. What are the signs and symptoms of SVC syndrome? The clinical presentation and the severity of the symptoms depend upon both the extent of the obstruction and the acuity of the obstruction itself. They usually develop around 2 weeks, and this is because the obstruction of the SVC causes increased venous pressure, so the blood gets rerouted through collateral vessels like the adagos, the internal mammary, and so on. But it takes weeks for these venous collaterals to dilate sufficiently to accommodate the blood that is now going through the superior vena cava. So what happens? The increased venous pressure in the upper body will cause edema of the face, of the neck, of the upper extremity, and also will cause face plethora because of the venostasis. All of these symptoms will be exacerbated by bending forward, lying down, or also by extending and elevating our upper extremities. Another very common symptom is dyspnea. So more than 60% of the patient will have shortness of breath, which is caused by the edema itself, but also by the fact that there is a reduced blood flow to the heart. Other symptoms are orthopnea or cough. As we said before, all of the obstruction will cause dilation of the chest vein collaterals that are opening up to reroute the blood, and there can be also conjunctival suffusion. What do we have to fear though? We have to fear the edema of the brain and the edema around the airway. The most alarming symptoms are the following: stridor and hoarseness. So they are caused by the compression of the larynx and of the pharynx due to the edema. And then if there is cerebral edema, then we need to be very, very careful with these patients. They will start to have headache, confusion, even symptoms due to ischemia like strokes basically. Now we can see some of the pictures that show the facial plethora here, so this very red face and all this dilation of the collaterals through the chest and the mediastinum. Another very typical sign is the Pemberton sign. It's not specific for SVC syndrome. We can find it in other diseases, but it's very classic that when there is like an obstruction in this area and we elevate the arms, then we will have a worsening edema of the face. This is due to the increasing pressure of the venous system. There are no universal charts to basically grade the symptoms and the signs of the SVC syndrome. This table is taken from UpToDate and just puts together the most frequent symptoms and signs and how we can differentiate from mild to life-threatening symptoms. So the most common ones that we're going to find are usually the edema of the head and the neck, the plethora, some mild dysphagia, some cough, some shortness of breath. These are all grade 1 or 2, so mild or moderate symptoms. We need to worry even more when we start to have signs of cerebral edema, so headache, dizziness, syncope. The syncope is due to the fact that there is reduced blood flow to the heart, so there can be a hemodynamic instability on these patients. Life-threatening symptoms, so grade 4, will be, of course, obtundation of the patient, stridor, but also syncope without precipitating factors. So a person that does not even have hypotension, but just like loses consciousness right away. So what do we do when we see one of these patients? Our workup will be, of course, first of all, getting a history of the patient. So trying to understand the duration of symptoms. Because if the patient has symptoms for only 2 days, then we know that the obstruction is very acute, versus a couple of weeks or some months, which means that the obstruction is progressing very, very slowly. The severity of the symptoms, of course, will be the most important part to triage the patient, and then we can try to see if the patient has a history of cancer, which will help in our differential, if the patient had any intravascular device placed recently. The diagnosis, though, it's not only with the symptoms, but also with the imaging. The first and foremost imaging that we will do is a CT chest with the contrast, which is important to see the vena cava itself. So basically, we will trump the ultrasound, we'll just go to the CT chest unless the patient cannot have any radiation. We can consider MRI of the chest in that case, or an ultrasound. The ultrasound, though, most likely will see if there is a thrombus, but will not see if there is a mass. Venography is usually not done, even though it, of course, will be the gold standard, but we will only jump to the venography if we need to do an intervention, so if the patient is acutely decompensating. Finally, the biopsy. The biopsy is always needed if we have a suspicion for cancer. It's never going to be an urgent procedure, so we will do it in case there is a mass that will be seen by a CAT scan. Of course, if there are other peripheral sites that are more easily accessible, then we will have a biopsy on another site, for example, a lymph node. But again, this is not going to be our resident level decision. Let's jump to the management. So, very important, there is no one specific treatment for all the SVC syndrome, but the treatment will depend on the etiology. The treatment is always multidisciplinary, so we will have multiple specialists kind of weighing in on the patient treatment. Remember, it's an emergency, so you need to consult oncology even at night, even if you don't think that the patient is decompensating, because they will kind of be aware of the patient and they might help you triage the patient. General principles that are not that helpful, but that you can still do at night, especially when you don't have a clue what to do. Elevate patient's head, just trying to kind of drain the fluids from the neck, and avoid overhydration. Most important question that you need to ask yourself, especially if it's night, do I have to call a screen? So that depends, of course, on the patient. So assess always airway patency, look for stridor, look for confusion, so assess the mental status of the patient. Vital signs, we said that the obstruction of the SVC can cause hemodynamic instability. So hypotension or hypoxia, these are all signs and symptoms that will have to maybe make you think about calling a screen. Let's go into the specifics, even though we don't really need to remember all of this. We will stage the patient with the signs and the symptoms. We saw before that chart, so if the patient has mild or moderate symptoms like edema, plethora, just some cough, we can kind of pause and decide what to do. If the patient has a history of malignancy, then we will have to do the tumor-specific treatment. If there is a device, we will have to remove it and do anticoagulation. If we have no clue why there's an obstruction and we only have imaging that might show a mass, then we will need to do a tissue biopsy. If there's nothing on the CAT scan, we might need to observe the patient. If the patient is in severe life-threatening SVC syndrome, so confusion, obtundation, syncope, stridor, then the first thing is calling a screen and stabilizing the patient. The different treatments are not something that we need to remember, so let's just very quickly go over them. The intravascular stent placement is the fastest way for symptom relief, so it's used for patients with life-threatening symptoms. The good thing is that it can be done before a biopsy because it will not compromise it. Steroids, usually dexamethasone, are only done if you already know the cause of the SVC syndrome, because otherwise they will compromise the tissue diagnosis. So never do it if you don't know why the SVC syndrome is happening. Radiotherapy needs a diagnosis because we need to know if the cancer will respond to radiotherapy. It's actually good for patients that have symptoms because it will quickly relieve them. Chemotherapy. Of course, this is not our call. It will be the oncologist to decide. Lastly, if we have an intravascular device which is causing a thrombus, then of course we will have to remove it, and then usually we will have both catheter-directed thrombolysis and anticoagulation for at least a period of time. All right, we are almost at the end of our talk. So what did we say today? Our take-home point will be to think about SVC syndrome when there's face plethora and dyspnea, especially if we have Pemberton sign. Always look for stridor and neurological signs because they are alarming, and then the treatment is always multidisciplinary. This is a handout with the summary of what we just said that you can quickly and easily print. Alright guys, thank you so much for your attention and have a really great day.